So when we look at my 20 pulmonologists in my group, there are 5 of us that do interstitial lung disease. You're going to find the same sort of thing in your communities where there's some guys that love this topic and there's some guys that are just looking for our most common interstitial lung disease, which is idiopathic pulmonary fibrosis. And I think you see when a radiologist comes with a scan out of your emergency departments, they'll often just say, there is pulmonary fibrosis, and you'll have pulmonary fibrosis across the chart for lots of different, and it's stuck in the medical record because it's electronic, and yet pulmonary fibrosis just means scar in the lung. It means that this is the topic, but now we have about 150 different diseases, one of which is idiopathic, and the other 149 causes have a specific etiology. And so when we're trying to get to the 60% of the pulmonary fibrosis cases that end up being idiopathic, we have 3 questions. Our questions are, is there a discernible cause? That means history. If not, does it appear to be on CT scan idiopathic pulmonary fibrosis? And if neither of the above, should a biopsy be done? And so these are the topics that we're going to structure our talk around. And importantly, this past year, many of you know that there have now been 2 new drugs that have come out through the FDA for specifically idiopathic pulmonary fibrosis, but no other of the 149 causes of pulmonary fibrosis that are out there of interstitial lung disease. So what else could it be if it's not IPF? Well, the list I showed you before of the causes we recognize and not. I just wanted to talk a little bit about autoimmune disease. We have a lot of disease on a chest CT scan that's associated with our connective tissue diseases. We think about 20% of all the interstitial lung diseases are associated with a connective tissue disease. If you have an established connective tissue disease, then we have specific patterns that we see with rheumatoid or with scleroderma or with Sjogren's disease. And these are unique to the disease itself. The ones that are common here obviously are rheumatoid arthritis. Rheumatoid arthritis, if you do CT scans in all comers with rheumatoid, about 30% of them have an interstitial abnormality on their CT scan. The problem is that it becomes clinically significant over the course of life in rheumatoid only about 5% of the time. So if rheumatoid is 5% of the US population, 5% of them have any clinical outcome of their interstitial lung disease, we're really talking about a very small percentage of our patients that end up having to be treated for rheumatoid interstitial lung disease. And yet there is no single trial that says if you treat their joint disease to clinical stability, that independently the interstitial lung disease defines treatment courses. So the point of actually going into rheumatoid here is that holds for all of our connective tissue diseases. If we treat the connective tissue disease aggressively enough, then typically what happens is we don't have to go over and above that to do additional treatment for the interstitial lung disease. The one of these is particularly hard to get a clinical assessment, though, of is scleroderma. How many people have scleroderma patients in their practice? Yeah, a few. And those individuals, the lung disease is the #1 cause of death and is often treatment defining. And so we will, in all scleroderma patients, be doing spirometry and typically at least 1 CT scan in the course of their lives. 70% of the CT scans have abnormality. We're really watching to see if it's progressive before initiating therapy. This has been the topic of scleroderma lung studies 1, 2, and 3 by the National Institute of Health that I was a part of. And the point here is that we really focus on scleroderma because of the interstitial lung disease and the pulmonary hypertension associated with it, with a different flavor than all the rest of the connective tissue diseases. Let's talk for a second about #2 on the list, hypersensitivity pneumonitis. HP is probably our 3rd most common interstitial lung disease behind sarcoidosis and IPF. Hypersensitivity means that you're inhaling an organic antigen to which you're allergic. Now, we recognize that if you have a cat in the house and you inhale cat dander and you're allergic to cats, you get asthma. Asthma is typically an IgE-mediated response. Hypersensitivity, on the other hand, is a cellular response. So we don't have a blood test that says that you have hypersensitivity pneumonitis compared to IPF. And if you inhale an antigen regularly, for instance, farmers' lungs, the guys are loading bales of hay their whole lives. They're thermophilic actinomyces and other fungal species inside all the wet bales of hay, that all those dust clouds that come out and are inhaled become the antigens that drive cellular delivery to the lungs and ultimate fibrosis. Then they have acute presentations during some of the blooms of fungal antigens they inhale, but others might be subacute over lots of years. And so the point here is that we're going through a hypersensitivity that is very, very hard to sort out at a clinical level, because most people present with chronic disease that's cellularly mediated with little spikes of exposures over time from mold in your house, or from how many different organic antigens are out there in the world. This is, 100,000 different sorts of grasses and trees, and organic means it had to grow at some time in your life. And so we'll see guys that are in the furniture industry, for instance, that when they carve the legs of birch, they get hypersensitivity, but if they work on oak, they don't. And so it's really one of these things where you have to do a lot of detailed testing. The tests are hard. We have blood tests that are called hypersensitivity panels that take common antigens and look for them. The problem is that if we have 100,000 different potential antigens, the common antigens we look for are the ones involved with common farmers' exposures, and importantly, the bird antigens. And so about 60% of hypersensitivity pneumonitis comes from bird fancier's disease. I don't know how many of you have, I'm not going to ask how many people have parrots or parakeets in the room, but these are nasty animals, and they shed antigen all over the house. And what happens is that if you go to a bird fancier's convention and actually take the number of individuals that have cellular responses to bird antigens, it's about 70% of all bird fanciers that have an immunologic response to bird protein. Bird protein usually comes from what passes through and into the cage as excrement, and then it becomes dust-like, and then it goes throughout the house and settles obviously in carpets and draperies and sofas and everything else there to be inhaled lifelong over the course of time of these individuals. And what happens in these chronic exposures is that you get lung injury, and what happens is that you then start having some subpleural fibrosis with honeycombing that looks identical to IPF. And we'll go through the CT scans in just a minute. And so it's very hard to figure out in a bird exposed individual if they have IPF or not. And now if we have a drug that works for IPF, should you give it to an individual that has a bird-exposed individual? And we really think that you can't have idiopathic disease if you have a bird in your house because of the frequency of birds and hypersensitivity pneumonitis. So what happens in these cases where we have bird exposure of any kind of chronic duration is, number one, the birds go outside the house, but number two, we think that you have two options, one of which is to move. And where are you going to move to? Well, you don't want to move to a house that has had birds before, so knowing the history of the homes that you live in becomes important. And secondarily, your other alternative is to rip out all carpets and all cloth out of the house and really do an industrial hygienist approach to cleaning the antigen out of these homes of individuals that have bird fanciers hypersensitivity pneumonitis, because it's causing death and disease. And of our lung transplant clinic, about a third of them have an interstitial lung disease, and about half of those have HP that's progressed. So just the point is that we're talking in generic terms about a very specific disease here, but you're getting the flavor here of what we're asking about patients. Is there mold in your house? What does your basement look like? Is there standing water anywhere? What kind of hobbies do you have? Do you have, are you doing anything with woodworking? Do you have exposures to metals or other things that might not be organic? And so these histories become very important in going through this list. We all know about asbestosis, silicosis. We can take questions on those at the end. Sarcoidosis, number 2 on our list behind IPF, very prominent granulomatous lung disease. We've been doing lots of studies trying to define the cause. We actually think that there is probably going to be a microbiome agenda to be able to figure out some sort of exposure that drives the antigen and lymphocyte proliferation of that disease. And then we have all these other rare interstitial lung disease, lymphangioliomyomatosis, the longest word in the medical language, and Langerhans cell histiocytosis, pulmonary alveolar proteinosis. And I'll give you a hint that I'm showing one of those diseases tomorrow in our cases. So what does this take? It's a good ILD workup is lots of history. Jobs, hobbies, molds, hot tubs. Hot tubs give you exposure to hypersensitivity through there are some molds, but hot tubs, warm water, allow mycobacteria to grow. And so these are the hypersensitivity associated with Mycobacterium avium complex. We know that MAC can cause infiltrative disease, but this is hypersensitivity from MAC associated with hot tubs. We've talked about the physical exams, cracked fingers associated with our myositis spectrum of diseases, arthritis, Raynaud's, very important. Spirometry and diffusion, we'll touch on that in a second, and then our laboratory evaluation of interstitial lung disease is heavily looking for the associations with our connective tissue diseases for which we actually add immunosuppressive therapy most of the time. Lastly, we'll go through some CT scans and the last part of our workup. All right, so we focused on spirometry first with obstructive diseases yesterday. We talked about restriction as the thing we had to exclude. I wanted to make a few points today about your spirometry. And so what happens in this situation when you start exhaling and now you only get 3 seconds before the audience starts coughing and you don't finish your 6-second expiratory time, and really you have emphysema or bad obstructive lung diseases? Well, that means your forced vital capacity stops short if you only have a 4-second exhalation, and now you've got an FEV1 and an FVC that are both depressed, and you misdiagnose restriction. So when we want to diagnose restriction on spirometry because we didn't get the long enough expiratory time to prove obstruction, the next test that we add is a thing called lung volumes. And these are done usually at hospital laboratories. We often do them with a diffusion test to look at the vascular injury response of whether it's there or not. And let's think about, I'm going to move all the way over on our tidal volume. We inspire fully, we expire fully, but we leave a volume inside of our lungs called residual volume. And of all of our interstitial lung diseases, the volume affected most first and almost universally is the restrictive volume, the RV first, and then it moves up into the FVC. And so what happens around our vital capacity is that with vital capacity being down from our interstitial lung disease and RV being down, our total lung capacity is definitely affected, whereas in the obstructive lung diseases, if anything, it's going to be preserved or be increased if you get hyperinflation. So if I'm moving and I don't know if my spirometry means I should go get a CT scan or whatever, one of the steps is to go to the hospital lab, get a set of lung volumes and diffusions, really know that you're dealing with true restrictive lung disease, and then move on into your CT scan and look for severity of interstitial lung disease that way. Well, this is the framework for our interstitial lung diseases. I think all of us recognize we have some of these that are known causes. We have some drug-induced interstitial lung disease. Listening through last lecture, we have a wonderful website in the lungs called pneumotox.com. And there's this guy in France, he reads the medical literature every day and has recorded the lung responses for the lung toxicities to all 360 different drugs that affect lung presentations with organizing pneumonia or fibrosis or asthma. And pneumotox.com is the website that he keeps up. And when you have enough individual case reports or case series of amiodarone or anything else, he'll write up the typical scenario of what this looks like in your practice. And so when we see an interstitial lung disease, first thing we do is we pull out the pneumotox.com website, go through all 32 of your medications that have been given to you in the past year, and figure out if there's a drug we definitely need to stop there. On the third one, sarcoidosis is a granulomatous interstitial lung disease, which needs a biopsy, although we have some typical patterns. We occasionally miss, if we don't biopsy, lymphangitic presentation of some of our lymphomas that have a presentation with large adenopathy, and so we really don't want to miss that one, and so we'll usually biopsy an organ to prove that you have sarcoidosis before moving into treatment. We can take questions on sarcoid at the end if you'd like to. And then we have our miscellaneous disorders that typically have typical CT patterns. But what has been so perplexing and is so hard for family practice and primary care and internists is this second bar, which are the idiopathic interstitial pneumonias, 60% of which are IPF. And so IPF comes in two forms. It comes as a genetic form, so we have pulmonary fibrosis families that will, I guess what I had two 70-year-old husband and wife in my practice whose son actually needed an open lung biopsy to prove his IPF and went on to lung transplant at the age of 40, as both of them were sitting in my clinic for treatment of pulmonary fibrosis. And so it's one of these, we know the genes, at least for about 90% of these. There are telomerase mutations. The point is that we have some gene tests out there. I don't think you have to use those, but send them to a center that knows something about interstitial lung disease, and they'll work through all those with these families that have pulmonary fibrosis. And then we have this whole group of alphabet soup, and let's just run through just so you've heard of them before. They are nonspecific interstitial pneumonia, or NSIP. NSIP is the histology associated with all of our connective tissue diseases, and when we do a biopsy and it pulls out this finding at the pathologist of NSIP, we often go back and look again for the connective tissue diseases with a lot more recommendations there. Number 2 on that list, AIP, acute interstitial pneumonia, is a presentation of ARDS. These are patients who have presented usually within 1 to 2 months of a rapidly progressive lung injury. When you biopsy, it looks like a diffuse alveolar damage. Number 3 on the list is respiratory bronchiolitis, interstitial lung disease, or RBILD. This disease is seen almost exclusively in cigarette smokers. So if you start doing CT scans of smoking individuals and see some peripheral basilar interstitial lung disease without honeycombing, then RBILD is usually present. Stopping smoking actually stabilizes that disease and is the treatment. And we do not have any evidence that steroids make any difference in that disease. The next one on the top is what used to be called BOOP, bronchiolitis obliterans with organizing pneumonia. But in the European and US consensus conference now a decade ago, we now call this disease cryptogenic organizing pneumonia, or COP. And so that was the European word. We got to keep on our side IPF because they called that cryptogenic fibrosing alveolitis in Europe. And so we got IPF. They got COP, and that was the way that COP evolved from BOOP. And so now everybody in the world calls this cryptogenic organizing pneumonia. A peripheral presentation of an alveolar infiltrate that can scar a little bit, often following respiratory viral illnesses, although there is an idiopathic form of this, and typically does respond to prednisone. So a very important recognition to make on a CT scan. Lymphocytic interstitial pneumonia, or LIP, number 5 on this list, is seen in 2 diseases, Sjogren's disease and in HIV. And this is a prednisone responsive interstitial lung disease. And the last one is DIP, or desquamative interstitial pneumonitis, also a cigarette smoking associated interstitial lung disease with alveolar infiltrate. So it kind of looks like a pneumonia, and a very patchy pneumonia. Stopping smoking, it gets better. Really no good trial that proves that prednisone makes a difference in outcome. So as you can see, these idiopathic interstitial pneumonias other than IPF are this alphabet soup that we keep changing the letters on, and makes it really, really hard for general practice to be able to sort out. But they have unique CT patterns. We're not going to go through all of them today, but when you start hearing these words, you've at least heard a little bit about them as we move into idiopathic pulmonary fibrosis. So our algorithm here goes suspected IPF. Is there an identifiable cause that would look like the pathology of idiopathic pulmonary fibrosis, which is called UIP, or usual interstitial pneumonitis? And if there's no, then we go right to the CT scan. And about 70% of our patients who we don't have a discernible cause will have a CT scan that looks fairly classic on this left side for UIP, which is the peripheral honeycombing. I'll show you those slides in just a second. We'll have IPF. And then if we're indeterminate or we have possible or inconsistent disease, we move on to the surgical lung biopsy. A lot of my colleagues around America will try and get away with transbronchial biopsies in the situation of working up an interstitial lung disease. We have some specific diseases that we can make a diagnosis for, including our infectious diseases, cancer, eosinophilic pneumonias, which are on the list. But we do not believe that we can make a good diagnosis of cryptogenic organizing pneumonia, diffuse alveolar damage, any of our idiopathic interstitial pneumonias on the basis of anything short of the surgical lung biopsy. That's a little bit hard, and there's some emerging technology called a cryobiopsy, where the bronchoscope goes down. We use liquid nitrogen-cooled catheters to freeze about a centimeter of tissue, and then we just jerk it out of the lung and hold our finger with our scope to hope it doesn't bleed too much. And so this new cryobiopsy is being done at a few centers, but gives us a bigger piece of tissue without having to do the 1 day between the ribs, thumb-sized piece of tissue for an open lung biopsy that is done usually by a thoracic surgeon, 1 day chest tube, and then discharged to home. Typically in a mild patient is a benign procedure. When you start adding pulmonary hypertension and a lot of oxygen requirements, I'll show you some of the toxicities of an open lung biopsy in a minute. But that's the open lung biopsy pathway. We also have coming a whole bunch of gene expression profiles. We think that if in 10 years from now we'll be able to actually recognize that, for instance, the hypersensitivity pneumonitis patients have different molecular pathways that are initiated compared to the IPF pathways. And so we'll be able, it's not going to be a single gene or a single test that does this, but they're going to be little profiles. And this is the difference between hypersensitivity on the right in these two panels and IPF on the left. There are a lot of differentially expressed genes. So that part's coming. So that gets us to our first case. First case is 68. He's in the emergency room where he's just had a CT scan for dyspnea to rule out pulmonary embolism. His shortness of breath has been worse today, but it's been present for at least 3 months, and he has no other illnesses. He denies arthritis or Raynaud's. He's a retired fireman. He works on computers in his spare time. He stopped smoking 14 years ago. He has had no birds and no hot tub. And this is his CT scan. And what are we looking for on a CT? We're looking for white stuff in the lungs. We're looking for its distribution of whether it is peripheral or central. We're looking for whether it is patchy or whether it's homogeneous. We're looking for the presence or absence of honeycombing. And then we're looking for the presence or absence of adenopathy. So those are the features that help us in our CT scan evaluation. So his diagnosis is most likely A, idiopathic pulmonary fibrosis, B, berylliosis, C, sarcoidosis, D, asbestosis. Please answer now. "133% think it's IPF. I like that. Okay, I think everybody's got the predominance of the right answer. The difference between IPF and asbestosis is obviously the exposure. And 90% of asbestosis cases will have asbestos pleural plaques associated with them. And so in that CT scan, we saw no asbestos pleural plaques. Borreliosis is associated with a granulomatous lung disease. It's very much like sarcoids, so you'll always see some adenopathy in a beryllium case, and because he worked on computers and may have had some exposure, but we saw no adenopathy on that scan. And this was a very typical scan of a patchy peripheral distribution with honeycombing. And so the correct diagnosis here is IPF. And that brings us to the discussion of what exactly is honeycombing. And I think we all know what honeycombing looks like in the honey. But in the lung, we're looking for at least 2 layers from the pleura coming in of having holes in the lungs. And the way this works when you actually look at it under the microscope, which is very much more sensitive for honeycombing than by a CT scan, is that it's scar that actually pulls apart the lung. And so in these areas of the ridges between the honeycomb, you'll see just bands of fibrosis, but it's pulled apart the lung parenchyma in between into actually a hole there. And so we define that not by a single hole on the pleura, but at least 2 layers of holes, and it can then progress throughout the lung even further. So more typical, we've got normal lung. Adjacent, we've got some fibrosis and honeycombing. Notice that we also get, in most areas of honeycombing, airways that we can see if you move up and down through the CT scan. And what that is a thing called traction bronchiectasis. It means the lung has fibrosis in that area and is pulling apart the small airways, so you can see an airway in the periphery of the lung that otherwise you would have only seen that size airway in a more central location. It's interesting, even though you've got bronchiectasis here. Bronchiectasis is a word that just means a large airway, but this is because it's due to traction. We actually don't see all the mucus and purulence associated with the IPF traction bronchiectasis as we do with some of our COPD patients that have a lot more of mucus phlegm and CF-like airways disease. And then also we see in all of our early IPFs this reticular change. We're looking for little tiny strands along the edge of the pleura of either lines or dots that usually involve the subpleural area and extend on in. These reticular changes are the first changes you'll see in rheumatoid and in our familial pulmonary fibrosis cases when we start CTing them serially over time. So what's going on? We think there's an injury to the lung, and because this is a disease so heavily associated with aging, we really don't understand all the heterogeneity of disease. When we start looking at this, we have all sorts of patterns. We think there's a subclinical lung injury happening, and then we make a diagnosis, and we have a fair degree of heterogeneity in our clinical presentations over time. I'm going to call you, we're going to talk about acute exacerbations here in a minute, these step care drops that sometimes lead to death in our patients and are reasons for hospitalizations. And then but it's a very rapidly progressive disease in most patients. Exacerbations happen in all lung diseases. Exacerbations of COPD we treat with steroids and sometimes antibiotics. Exacerbations in IPF often bring patients to the hospital. They're associated with about 70% of patients not leaving the hospital when they show up. And so it's one of these situations where we like to have the discussion on the front side when IPF comes in the hospital of, do you want to be on the ventilator and what else can you do? We have no treatment trials that actually show that any therapy that is given makes a difference in outcome. And so we look for other things. So if somebody's suddenly worse with their IPF, we're not going to not treat with antibiotics. We'll look for pulmonary emboli. We'll look for concomitant heart failure. But there is a lack of science in the exacerbation of IPF, even though my American Thoracic Society put out a statement, but not a guideline, because there's no data that shows clinical improvement with IPF for acute exacerbations. But it occurs in about 10% of IPF patients every year. And often is that process that leads to death, and you should at least have heard of the word acute exacerbation of IPF. We think a lot of these are micro-injuries, and it's interesting that our pathology, when we do it around exacerbation, looks like it's the alveolar and small airway epithelium that's involved, and then a fibroblast response happens. And so we get these things called fibroblastic foci that happen in our biopsies. And in your handout, I kind of put the proposed pathogenesis where the airway gets damaged, we get a little clot, and then the fibroblastic response then responds and then is not abated. Part of the reason that fibroblastic responses are sometimes not abated in our pulmonary fibrosis patients is lack of telomerase, and so this whole process of aging, and telomerase actually limits the degree of your response to telomeres, which are part of our DNA strands. So if you can't turn off and shut down parts of your DNA to keep from proliferation ongoing, then this process would be worse with an aging process, which is what we see in pulmonary fibrosis. And many of these patients are in their sometimes 70s, 80s, and then 90s. Okay, so case number 2, 74-year-old man diagnosed with IPF by open lung biopsy 4 years ago. He's been slowly getting short of breath, and exercise is limited to about 100 feet. He wears 2 liters of oxygen at rest and then increases this to 4 liters with exercise. He wants to know how to treat his new but non-productive cough. On your evaluation at 2 liters, his O2 saturation is 90%. He has Velcro crackles at both lung bases, and he's afebrile. You should spend your 15 minutes talking to him about A, how much oxygen to be on with rest, exercise, and sleep. B, how steroids can sometimes help with the cough of IPF. C, if a CT scan should be repeated to determine if he has progression of disease. Or D, his end-of-life wishes concerning hospice, hospitalization, and mechanical ventilation. Please answer now. Nobody's going to deviate from 100%. And actually, I believe that is the right answer here, because we see too often Mr. Jones coming in, and nobody in the clinic has really talked about this end of life with IPF. And it is a disease where we put people, if we can get it paid for, into pulmonary rehab, and they're out there and we're encouraging them to keep their muscles as strong as they can go and walk as far, and we'll crank up the oxygen. Unlike COPD, we have no limits on oxygen here, so we've got people on 2 10-liter concentrators Y connected together to give them enough oxygen so they can run on their treadmill in their bedroom, just so they can keep their exercise going. But it's very oxygen requiring disease to keep them moving. But when they come to the hospital after having an acute exacerbation, we really don't have too much more that we can do here. And so it's amazing how many people have not had this discussion about what happens is their exercise limitation slowly begins to get shorter and shorter, and you can see what's happening here. The disease course in a very large series out of UCSF in San Francisco was median survival of 3.8 years after a diagnosis of IPF, and about 4.3 years after the onset of first symptoms. So let's kind of look at IPF compared to cancer. IPF is the black bar, and these are all of our cancers in the body. The 2 that are the lowest here are pancreatic and lung cancer, so we do a little bit better at IPF than those 2. But the point is we act like this is a cancer, and yet almost nobody is getting to hospice with their IPF as it gets progressive. So the point here is IPF, really bad disease. You want to be very specific with the diagnosis, because all those other idiopathic interstitial pneumonias I showed you have great survival. You can live for 10 years with NSIP and with some of our smoking-related interstitial lung diseases if you quit smoking. So that's why the IPF diagnosis is really important to make, and we try and make it as specifically as we can. So we do know that survival is better in our connective tissue-related diseases. And then our common clinical dilemma is what to do with these patients if you don't want to go to open lung biopsy, or should you go, and if so, to who, and should you ever pass out prednisone the way we did 15 years ago, just to see if it helps. And so this is the conundrum. I'll show you the trials that have been done. So let's start with surgical lung biopsy. This is a series out of the University of Pennsylvania that showed that 60-day mortality after an open lung biopsy was 4.4%. Prolonged air leaks, 4.4%. Pneumonia is 2.9%. Hospital readmissions within 60 days, 10.7%. The point is that this is not a completely benign procedure. And the further down the pathway you get with worse comorbid diseases or severity of your interstitial lung disease, it becomes even a worse procedure. So we take, if you had a 50-year-old individual otherwise healthy except for the interstitial lung diseases, we really don't see this degree. But if you take grandpa that has a little bit of heart failure and he's 72 years old and take him to open lung biopsy, it really is not such a benign procedure. And so I think we recognize that we try and risk stratify. We don't do open lung biopsies if anybody has any pulmonary hypertension. It's just a marker for bad outcome in these individuals that have an interstitial lung disease that bad. Well, the big topic here 2 years ago was that many of us had seen the studies, the randomized controlled trial from Seattle from 1976 that compared 8 patients on prednisone, azathioprine with placebo showing improved outcomes. And this was prednisone, azathioprine, which we'd used for about 15 years. And then the Europeans came in and showed a study where N-acetylcysteine, go to any of your nutrition stores and get a pill of NAC, could make a difference in outcome. Randomized controls trial perspective showing a little bit of benefit in FVC at the end of 2 years. And so the NIH formed a idiopathic pulmonary fibrosis treatment network. 20 centers enrolled a bunch of patients, and so the trial design for PANTHER was one of 3 different arms, one of which was prednisone, azathioprine, and NAC, all taken as our best therapy, compared to placebo, compared to NAC alone. And what happened in this trial was stopped early because of excess mortality due to pulmonary exacerbations in the prednisone, azathioprine, NAC arm. And so there's nobody in America using prednisone for idiopathic pulmonary fibrosis anymore. So if you're still passing out steroids, you ought to have a specific interstitial lung disease for which you're doing that. Sarcoidosis, hypersensitivity pneumonitis, diseases that we know are steroid responsive, but you shouldn't be doing it and writing pulmonary fibrosis in your chart or idiopathic pulmonary fibrosis. Excess mortality, bad outcomes using immunosuppressive therapy in IPF. Connective tissue diseases, rheumatoid, scleroderma, we're still into doing all this, and prednisone cyclophosphamide better than placebo in scleroderma lung 1 study. And so making the right diagnosis will kind of win the day in all of these. I want to tell you about our 2 new drugs. They both came out in the same issue of the New England Journal of Medicine last fall. The first of these was Nintedanib, which is a triple kinase inhibitor. And the trial design for all of these is the FDA is going to make us do 52-week trials to look at FVC. And we recognize that if you're on placebo here, FVC decline is associated with mortality, but these are not mortality endpointed trials that the FDA has challenged the pulmonary community to do. What happens if you look over time at placebo versus either of these 2 drugs is that you foreshorten, but you do not abrogate all FVC declines, so that if you have, back up, so that your number of patients that are having change from baseline FVC is half as many in the group on drug compared to placebo here. The second drug, which is pirfenidone, has had a tortuous path through its regulatory pathways, but it on its 3rd trial actually had enough data there to also slow IPF progression by 50%. And this is mean change in milliliters of FVC, but similar outcomes for other FVC endpointed trials. Pirfenidone, we think, works by decreasing fibrosis in animal models. The mechanism is not particularly clear. Again, 52-week trials. And so when you start looking at primary outcomes, which are FVC, that are identical between the 2 trials, you next turn to try and figure out which drug's better, which is the natural next question, into secondary endpoints, and some of these were examined or not examined. The greens are hitting positive endpoints. The not greens here are either not examined or did not show trends towards improved endpoint. Progression-free survival, a little bit better for pirfenidone. Acute exacerbation risk, a little bit better for nintedanib. Neither of them showed a mortality reduction in their endpoints, but both of them got FDA approved on the same day. And so we've got now 2 drugs, both landed in the New England Journal of Medicine the same day, and both FDA approved the same day, recognizing that it's really hard to figure out which one to use in clinical practice. We do know that the inclusion criteria were pretty similar for all 3 of these trials. Capacity and Ascend were the 2 pirfenidone trials. Impulsus was the trial for nintedanib. And I guess the last thing to say is that side effects will sometimes make the day. Pirfenidone has myalgias and fever, and Impulsus tends to, nintedanib has more diarrhea associated with it. So if you've got a constipated old guy with IPF, then that's your drug. Otherwise, pirfenidone might be your drug. But the point is that we go through the side effect profiles of these drugs and turn that question around to patient preferences oftentimes in the clinic. They both have enough GI side effects associated with them that we have not done the trial of comparing the 2 of them together. And the fact that both of them are about $100,000 a year means that we don't have a whole lot of flavor to actually do the combination trial compared to one or the other, knowing that it's going to take now 1,000-person trials to actually show that combination therapy has benefits over and above monotherapy in this disease. So I think we were backed into a corner. We're probably not going to have any new IPF drugs for a while, just because now if we shorten our FVC declines, it's going to be even harder to prove the second drug has benefit in this condition. I guess the last thing to say about these 2 drugs before we end is that both of them were studied in a group of patients whose FVC at baseline was more than 50% predicted. It's about 2/3 of patients with IPF that would meet this milder inclusion criteria. But if you get an FVC below 50%, we have this point where people don't really drop their FVC much lower before they die. And there are a lot of these patients right before death that have lower than 50% FVCs. And yet the FDA in their wisdom didn't limit the indication, although some drug insurance companies might, to having an FVC greater than 50% before you prescribe drug. If we're trying to shorten the duration change the slope of FVC decline, then obviously what that means for your patients is that the sooner you begin, the more benefit you're going to have, but also the more cost you're going to entail. And so this whole process of what the FDA did with these drugs, they didn't put an upper limit of FVC, they didn't put a lower limit. They say the disease state, IPF, now has 2 drugs that are approved for the disease state without putting limits on how bad your patients need to be. And I personally agree with that recommendation. The companies that make these drugs obviously would like to extend them to other interstitial lung diseases. They'd like to give your severe asbestosis patient, for instance, an antifibrotic drug that may or may not work. So how are they going to do that? Do you think we can find 400 asbestosis patients to do a placebo versus drug trial? Probably not these days. And so what's going to next happen, we think, is that all these other interstitial lung diseases may be grouped the same way cystic fibrosis genotypes were grouped to study some of our more specific drugs. And so a lot of stuff happening in the interstitial lung diseases that you'll see coming out in some of your medical journals. But the point here is that the FDA, in their wisdom, we now have 2 drugs we didn't have before. Questions on the drugs real quickly before we move? How many people have patients on these drugs already in their practice? Yeah, 1. Okay, so a lot of enthusiasm for these $100,000 drugs, huh? The last topics here about reflux and the things we can do. We've recognized for years that there's a lot of reflux in our idiopathic pulmonary fibrosis patients. And now that we know that this is an epithelial injury-driven disease, we wonder if acid spillover might be part of that injury to the airway epithelium in particularly our older patients that have some dysphagia and reflux. And that's been found in every series. And so there are some randomized controlled trials of Nissen fundoplication because everybody's on a PPI with their pulmonary fibrosis these days. And I think that trial is going to be hard to do. One randomized trial that has been done showed improved survival on a gastroesophageal reflux medication regimen compared to placebo. It wasn't a large difference, but it did hit statistical significance. And that leads us to the American Thoracic Society IPF guidelines that have come out, and now they're going to be coming out about every 2 or 3 years. And I think it's going to be hard to see from the back of the room, but our 2015 guidelines here, we have lots of strong recommendations against in the guideline. No steroids, no immune suppression, and then we have some of these things called conditional recommendations. And a conditional recommendation, importantly, has meaning. And just recognize this isn't a full, you gotta do it kind of recommendation, but we formulate conditional recommendations to have 3 different voices. One's to the patient, and the patient says the majority of individuals in this situation would want the suggested course of action, but it's okay, many would not. So some individuals just don't want to treat it, that's fine. Your voice is the clinician voice. You recognizes that different treatment choices will be appropriate for individual patients, and you'll help each patient arrive at a management decision consistent with his or her own values and preferences. And formal decision aids are likely to be needed to help individuals make decisions. And so this is having that conversation. We do this at our pulmonary fibrosis clinics all the time. Sometimes that is a money-centric discussion, and sometimes it's a side effect, and we show them the trials. We talk about the 2 drugs. We have choices these days, and these are hard choices to make sometime. And then for regulatory and policymakers, it means the recommendation can be adopted as policy in most situations. And so most payers are actually taking on the first drug for pulmonary fibrosis for IPF that has ever been developed and paying for it these days, recognizing that this is really a breakthrough after 20 years of working very, very hard to have well-designed clinical trials, prospective, placebo-controlled, multi-center that show actually FVC benefits, and then the challenge is to advance those on to mortality benefits in some of the trials. So conclusions, new therapies are available for IPF, the most aggressive and morbid interstitial lung disease. Early diagnosis and referral are in the hands of primary care. These are the guys that come to you with the CT scan from the emergency room, or have a little bit of dyspnea or some restriction on spirometry, for which you advance to a CT scan, which is our most important test. Restrictive spirometry, you got to work it up. That includes the CT scan, and interstitial lung disease is not helped by inhalers.